Our next talk here, and we're sitting right on schedule, I think. 8:50, we're actually a couple minutes ahead of schedule, so this is fantastic. The next speaker here will be a collection of speakers. Heather will be back up here again as the lab manager of Prairie Ridge, Columbus. Sherry Bisbee, she's also at Prairie Ridge, Columbus. We'll also have Michael Keeney, he's a clinical pharmacist, Emplify Health in Green Bay, and Tyler Radke as the director of lab and pathology at Emplify Health as well, okay? I'll let those speakers, if they have any extra additional information that they want to make digestible for the rest of you, I'll let them speak on that behalf, but I'll give them the floor, and our next talk is Laboratory Technology to Pharmacy Response. Thank you.
Tyler, are we just coming up one at a time or as a group? I know I'm first, but...
Yeah, you are first, yeah. I have to step up on that talk.
Yep. Okay. All right.
We're running ahead and
Okay. I'll try to go slow. Tyler's on call today, so he's trying to balance some other commitments. All right, so the idea for this talk, Laboratory Technology to Pharmacy Response, is to look at some of the results and data that we generate in the lab and how it's used by pharmacy or even maybe a provider to treat the patient. So we can give them a lot of information, right? But does it even give any value? Like, do we just keep giving them information and they're like, that's not what I care about? Like, I only care about one thing and you didn't give it to me yet. All right, so these are the objectives for today. Discuss common lab technologies in small and large healthcare organizations, review potential future emerging technologies, discuss pharmacy workflows in a rural setting, versus a larger institution with antimicrobial stewardship coverage, and then understand how lab results are being used in pharmacy response in sepsis and other disease states. So this is kind of a tag team approach. I'm kind of giving my perspective from the small, rural side of things. Tyler's gonna share his lab experience from a larger facility, and then we have two pharmacists kind of helping us out today from the two organizations as well. All right, so first thing is kind of just a general overview blood culture workup, right? So we start with our blood culture bottles. After maybe 18 to 24 hours, we get some growth. We're gonna gram stain. I don't know that I have a pointer. If we're lucky, we have a blood culture ID system that can maybe give us an ID in an hour after that gram stain. But then we have arrows going down to that bottom left corner of the chart. So we're sending a gram stain result to the chart. We're sending maybe a BCID to the chart. And then we're gonna plate it and do our ID susceptibility, and that will go to the chart. So several different results going to the chart for pharmacy to look at throughout the course of that one blood culture. Or maybe yours looks like this, and you do a gram stain and put it in a car and send it somewhere else, and let them do the rest. So first iClicker question for you is, what process does your lab use to work up your blood cultures? A, you collect blood cultures, but then you send the whole bottle to a reference lab or a core lab. B, you incubate it, you maybe do some minimal processing like a gram stain, and then you send it out. C, you incubate, you process, you do a multiplex PCR, and then maybe you send the susceptibility, the plates get sent out. D, you do, let's see, these look the same to me. Oh, D, you do it, but you don't use a MALDI, and E, you're gonna use a MALDI as part of your ID AST. All right, let me turn it on. Oops. And then I can. All right, so it looks like most of us, the biggest chunk, are doing the processing in-house between D&E, maybe a MALDI, maybe not a MALDI, but most of us are doing the work in our own facility. All right. All right, so we're not going to talk a whole lot about workup. We have those breakout sessions earlier to kind of talk through some of those details. So just kind of an overview. So we have our blood culture bottles, right? Probably putting it in one of these three systems between the BacTech and the BacT-Alert and the Virtuo. It will hold your bottle till it says it's positive, right? And that's when we pull it out. Gram stain. Next step would be our gram stain. So I'm going to let Eric talk about how to do a gram stain, but I'm just going through kind of some pointers. So your organism size and shape can be quite different from your blood culture bottle than they look on a plate. You want to report your gram stain results immediately to the provider once you have them. Be aware of precipitate matter. Those blood culture bottles have stuff that will stain purple even though it's not an organism. And then this is a recommendation from the ASM Clinical Microbiology Handbook. The written report of that gram stain should include the number of positive cultures compared with the total number of samples collected. So gram stain, gram-positive cocci in one of two bottles. So not saying you have to, just sharing what's in the ASM handbook. So how do you report gram stains from blood cultures? Gram stain interpretation only, gram stain interpretation with the number of bottles positive, gram stain interpretation with the number of bottles collected and the number positive, or we don't even do gram stains in-house. So B would be I have two, gram-positive cocci in 2 bottles, and C would be I have gram-positive cocci in 2 out of 4 bottles. All right. So everyone does their own gram stains. Looks like there's some interpretation only. It looks like there's a good split here between all of us. I put this question in here. I can share from talking with Sherry. This is something that Sherry as a pharmacist and I talked about a couple weeks ago, that from a pharmacy perspective, unless they thoroughly understand how blood culture ordering works, how many bottles, if you order 1 blood culture, you get 2 bottles. Unless they really understand that process, giving them a gram-positive cocci doesn't tell them much information. It doesn't tell them whether they should lead toward contaminant or not contaminant, or this is, in every collection. All right, this is a slide I just borrowed from a BioMerieux, just did a webinar on their Reveal. I only took it because it shares the new 2025 guidelines for diagnosing a bloodstream infection. So this came from the clinical microbiology. So the guidelines are to use a rapid testing of your bloodstream infection. So some type of rapid blood culture ID is now the recommended guidelines for your blood cultures. So not that you have to do it in your own facility, but maybe think about having a place that you can send your bottle to get that rapid blood culture ID. And then this goes through some of the reasons why they made that guideline, the benefits to the patient if you can give a rapid ID. So blood culture ID, this is your rapid multiplex systems. There's a variety of platforms. We're gonna share all of those here. Typically, they give you a result in 1 to 2 hours. PCR and NAT directly from a positive blood culture bottle. Platforms are available for many gram-positive and gram-negative organisms, as well as some yeast. And most of these platforms also contain some resistance markers. I just listed some of them here. All right, so is susceptibility needed? So you did this blood culture ID panel, right? It gave resistance markers. Do you even need to give them a susceptibility? So you did a BCID, you got a Staph aureus, MEK positive. Here I have an MRSA in my blood culture. Is there any value in spending 2 more days to be able to give the pharmacist a susceptibility when they already know it's a Staph aureus in their blood culture? So that's my next eye clicker for you. No, you already know you're going to give the patient Vanco anyway. B, yes, there's a value, but I don't know why. C, yes, these values are important in determining the treatment regimen. Or D, I think this is a trick question. We will revisit some of these questions later with pharmacy. All right, overwhelming answer of C. Yes, we need a susceptibility. These values are used in determining treatment for the patient. All right, we have our blood culture ID. Culture workup is our next step, right? We're gonna plate it to media. Maybe we're gonna use some discs for some quick ID, things like that. Then we're gonna do our susceptibility. So our next question before we get answers from pharmacy at the end, how do you handle susceptibility results for a standard blood culture isolate? A, you're giving interpretations only, resistant, susceptible, down the list. B, you're gonna give MIC and interpretation from the instrument. So from your Vitek, whatever Vitek said, that's what I'm reporting. C, I'll give MIC and interpretations only if the Vitek didn't make changes, right? Sometimes it'll say like, I'm gonna change this to resistant because criteria are met. So if it changes it, I'm not gonna report an MIC. I'm only gonna report MIC if it's no changes. The other option is we don't do our susceptibility. All right, so most of us are reporting it straight from the instrument. What the instrument gives us, that's what we're gonna report. There are some labs in here, I see there's 11, that don't report that MIC if the algorithms changed your interpretation, right? So if your algorithm changed it to resistant, maybe hold your MIC off so it's not confusing for the pharmacist down the road. All right, I'm gonna turn it over to Sherry for our next slides. So Sherry Bisbee is a clinical pharmacist at our facility, so she's gonna kind of go through some of the pharmacy side of what goes on for these patients.
Hi everyone, my name is Sherry. I am from Prairie Ridge Health Hospital in Columbus, Wisconsin. Prairie Ridge Health is a 25-bed critical access hospital in Columbus. We do have a small 4-bed ICU. We have an expanding ortho and OB department and a surgical services department. Pharmacy is in-house weekdays from 7 a.m. to 3:30 p.m. and weekends and holidays from 7 a.m. to 1 p.m. While we're not on site, our pharmacy is covered by our larger affiliated institution, SSM Health in Madison. So these SSM Health pharmacists will help to manage our overnight orders and order any pharmacy to dose medications. So we do have pharmacy consulted medications like vancomycin, aminoglycosides, warfarin, couple of pharmacy to dose medications. So Prairie Ridge Health does provide a handoff to these pharmacists on a nightly basis, and the SSM pharmacist may leave notes in the electronic health record for the next day as well. The next slide here shows an empiric, or shows a list of how we would manage antimicrobial therapy or management in the hospital. So providers are recommended to follow empiric therapy that's selected from the SSM Health infectious disease pathways or our local antibiogram that's put together by the laboratory. So the Prairie Ridge Health pharmacists monitor microbiology data on a daily basis. We want to ensure timely administration of an antibiotic for the identified organism and to recommend de-escalation and discontinuation when therapy needs to be narrowed. So we'll do this on a daily basis by providing an antimicrobial note, and I'll show you in a few slides what this looks like. Prairie Ridge Health does have access to infectious disease when it's necessary or when complications arise. However, we don't have ID on site. In fact, they need to be consulted first. So once the infectious disease team is consulted, they'll generally come on site just once a week. However, consults can occur over the phone if they're necessary as well. The next slide here just shows some variations between pharmacies in a larger institution like SSM Health or Prairie Ridge Health Pharmacy, a more rural system. So we share or adopt more of an affiliated structure. Prairie Ridge Health utilizes these protocols, order sets, and infectious disease pathways from our larger affiliated SSM. This can provide challenges due to differences in our formularies. We do have different ability to order particular medications. Providers have different access, and we don't have much of an ability to update or change any of this information. We do contract out to Madison emergency physicians, so there are ER physicians that travel to different hospitals. A lot of times they'll use their own preferred order sets or preferred way of ordering medications that may be different than our staff is familiar with. So sometimes things need to be changed when the patient gets admitted to the floor. I did mention a little bit about infectious disease, so our institutions or other larger institutions may have more of a specific ID pharmacist or physician that's rounding on a daily basis. While we are antimicrobial stewardship certified, my colleague and I do not are only focused on antibiotics. We do have other clinical duties we have to perform throughout the day. So having these infectious disease physicians and pharmacists that are solely focused on antibiotics can be really beneficial. They have more expertise in this. They can help provide more guidance on those contaminants or whether something is truly infectious. They can allow for sooner de-escalation or discontinuation when appropriate. For drug inventory, smaller institutions like Prairie Ridge Health may have a more restricted drug inventory. We don't have the same ability to order more expensive antimicrobials. And then finally, Prairie Ridge Health does utilize more of a post-prescription audit and review process of antimicrobials rather than a pre-authorization. So rather than a physician having to have a prior authorization to use the medication, our providers can order a medication, allow a first dose of a medication to be provided without a delay, and then the pharmacy team will review that antibiotic when appropriate. The final slide here is just to show you an example of our daily antimicrobial monitoring notes. So pharmacists will be consulted to provide specific drug therapy monitoring for drugs like vancomycin or aminoglycosides or anticoag, but that will be documented in a separate note. This is just purely a note we'll do on a daily basis. So we use the laboratory data and culture to provide a recommendation or assessment about what we're treating. So we'll first provide a description on what the patient's being treated for, the day of therapy that they're currently on. We'll list any allergies and current vitals. We'll list recent labs. So some of these may show some of those sepsis markers, so white blood cell count, procalcitonin that are important, and we trend those to see how we should be providing therapy. We'll list the cultures and the relevant microbiology data. We'll list any relevant imaging, so chest x-ray impressions, CT scans, and then finally a list of any antimicrobials that are prescribed. Finally, we will show the pharmacy assessment. So the first thing we'll do is look at the recommended length of the antimicrobial treatment. So we'll want to list what sources we've used, whether it's primary literature or infectious disease pathways that are provided by SSM, whatever source we use. And then we do comment on whether the appropriate, whether the current day of therapy is appropriate at the time. We do want to encourage physicians to add an end date or stop date to the antimicrobial so that we know that we're not prolonging unnecessary therapy. We do list the allergies on file and whether this is going to impact our treatment. Number 3 there shows the current antimicrobial regimen, and we assess whether this is appropriate for the indication. So we'll list the resource that we use, whether we're looking at past cultures, previous cultures, whether the cultures are still pending, or maybe we have some resistant markers that we're using. And then for bullet point 4 there, we do comment on the current dosing regimen. So we have a pharmacy protocol where we can change or adjust the dose based on renal function. So especially in sepsis patients where their renal function may be changing, maybe they have augmented clearance or they have acute kidney injury, we'll want to monitor that renal function and adjust as appropriate. We also may look at, so we may look at those MIC values here and assess whether, the drug is even appropriate based on those values. So if the MIC is above 2 for vancomycin, maybe we won't choose that. Or maybe if the patient's on a beta-lactam and the MIC is higher, we may need to use extended infusion interval dosing. So we'll look at whether the dosing regimen is appropriate. 5, we'll list whether the cultures are still pending or if we have finalized cultures there. And then finally, we will comment on whether the antibiotics are currently administered intravenously or orally. And then we'll comment on whether we recommend switching to oral therapy or not. We do also have an IV to oral protocol pharmacists can use based on bioavailability of the drug and whether we should switch those to oral therapy. And then down below, we'll just list any comments by day and what's important, what we're still monitoring for the day. And we'll use all this information, collect it, and use it for our quarterly antimicrobial stewardship meetings.
I don't think Tyler's ready yet. One of the reasons I asked Sherry to share that note, so that is something that pharmacy note that is raved about by all of our providers. So many of our physicians don't even take the time necessarily to go into chart review and click on the labs or click on the images. They'll go straight to that pharmacy note because it has all of the information they care about for their patient in one place, and it's updated every single day. So that's something our pharmacist started several years ago and has been a huge help to our providers. I'm going to try to start Tyler's slides, and hopefully I give the information he was intending. So the first thing he just wanted to share is kind of playing off of Sherry mentioned order sets. So this is some screenshots that Tyler gathered from the emergency room versus inpatient. Both departments have a sepsis order set. You can see they're a little bit different depending on where that patient is located, but it's not just labs, right? There'll be some antibiotics associated with this. Here's your cultures. I don't know on the left side. It looks like he only has the labs in there, but I know that if you made this bigger, if the screen was big enough to see it all, you would also have, Tyler's here, come on. So these order sets will also contain your antibiotics, your imaging studies if needed, like a chest x-ray, things like that. But this shows you some of the options that are maybe recommended to be available for lab, for your sepsis workup.
All right. Thanks, Heather. All right.
Yeah, as Heather was already describing, I also included it just a nice depiction of what you might see on an inpatient versus ED setting and some of the additional cultures that are out there that providers may indicate or may maybe see as indicated as well. But moving forward here, when we're talking about sepsis, a lot of us, we think about the process of blood culture workups, and lately, this field specifically, there's been a lot of emerging technology, and the great article out here in the Journal of Clin Microbiology that you can go and read about these different technologies. But a lot of this is really looking at how do we get to that susceptibility result sooner, right? And when we think about the principles of technology that are in place here, we're seeing a lot of new things be utilized that historically haven't been utilized in this space. So I'm not going to jump into each of these individually, but a lot of this is the conversation about getting more to a direct AST and some of the technologies that are there. So recommend that article as a good piece to go and review for some of the emerging stuff that's coming out. And as a focus of this conversation as a whole too, is as we're looking at a lot of this emerging tech, you as a microbiologist, from time to time, you may get visited by vendors, and a lot of times the vendors come forward and they're like, look at this new technology we have, this is going to be great, it's going to do all these wonderful things, and they're trying to sell you a product at the end of the day. And I like to think this presentation specifically, as we're talking about the pharmacy value side, and that'll be a lot of what we'll look to Sherry and Michael on is, they're trying to sell us on all these things, and is there actually value in speeding up certain parts of this process? So there's a number of different laboratory outputs that go into a sepsis workup, and some different stages within that. So there's a lot of, there's some things that go into the blood-based markers, right? Direct from peripheral blood draw. What are some of the tools that pharmacy might be looking at, or the provider might be looking at? They're going to directly be potentially utilized by them as they're working up patients of suspected sepsis. And we're all familiar with CBC, lactic acid, procalcitonin. The MDW is one that's a little bit newer on you being used for some of the CBC values as another add-in there. And then, NAAT plus magnetic resonance, another technology. These are all ones that have kind of been out there we're probably somewhat familiar with or relatively well familiar with. In red on the left side there, you'll host immune response biomarkers and the cell-free DNA next-generation sequencing. This is more of that emerging technology where it's not widespread in the industry yet. Stuff that, Dr. Ledebauer might speak to as well in his presentation, but things that you should be starting to have an eye on, be aware of. And again, think about that, the downstream clinical impact. Is this giving a value to the pharmacist, to the provider, that's actually going to impact patient care? Because a lot of times what we're doing in lab, and as Heather alluded to at the start of this too, was we produce a lot of stuff, a lot of values for our team. And sometimes we think of ourselves as factories. We might be overproducing things, overproducing values, thinking it's having impact. And it's hard to know that if we're not actually having that dialogue with the pharmacist, with the ID, with the care team to understand, is this actually impactful for you? Or is it just information that's sitting out there and you're not looking at it for 8 hours? But moving down the line here, gram stain report, obviously that's going to the chart pretty quick. Then kind of the next phase there, you've got your multiplex molecular, where you might have a combo panel, a gram-neg panel, a gram-pos panel. And then oftentimes there's some genomic resistance markers that are in there that may be useful to treatment care decisions. If it's negative, maybe it's not useful. So if it's positive, it probably is. Organism ID, generally the next step in that kind of process of a laboratory output for sepsis. Again, in black are the things that we're well familiar with today. Down at the bottom there, that one's in orange. The only reason I have it in orange is because it's paired up with the next one next to it. And then finally, kind of getting to the end point for us from a microbiology standpoint is the antimicrobial susceptibility testing. And we're all very familiar with, biochemical and phenotypic methods for producing that susceptibility result. Contrast it a little bit with the genomic resistance markers. Guidance today is still to follow up any kind of organism ID with true phenotypic testing, because genotypic only gets you so far. We don't know quite enough yet to be able to base everything in terms of treatment decisions just off genotypic. In red here, the volatile organic compounds, that was in single cell imaging. Those were both kind of alluded to in that prior slide with the JCM article. The volatile organic compounds, you might be familiar with the new Vitek Reveal system that's out there that uses that technology. I should say that the cell-free DNA NGS, that's Carius's technology. That's out there. Let's see, the orange, I think that was the pheno, I can't remember the specific name of it, but it uses kind of a combination of, we think of fish, and fish used to be something that a lot of people used in blood culture identification, kind of gets you that rapid identification of, is it an E. coli, or is it a Klebsiella, or is it a Staph aureus? You had a couple different bugs you could identify, I'll call it relatively quickly, couple hours, 2-3 hours, with fish. But that's now being paired with the morphokinetic cellular analysis. So if you can get that ID off fish right away, you're able to actually do kind of a rapid AST based off of that actual cellular analysis over time. And it's oftentimes potentially like a microscopic observation of how those cells are reacting in that system. And then broth microdilution direct. So actually taking directly from a broth microdilution and going from there. So again, just some laboratory outputs that you're well familiar with today, as well as some of the other emerging technology, and we're seeing where these things are landing. So when you think about what we've been used to over time, there's kind of a lot of emerging stuff that's happening, and just to be aware of it. And again, think about, how is this actually impacting? Does this actually have clinical value downstream? So I'm gonna call Michael up here to take some of the pharmacy stuff. So Michael is from our institution, Bellin Health, Emplify Health in Green Bay. And Michael, I'll let you kind of speak to more your role and what you've got.
Oh, sure. Are there notes? I had some notes I wanted to talk on for some of these slides. Okay, great. So hello, I'm Michael, clinical pharmacist at Bellin. Work with Tyler there. So some of this, is going to be a duplication of review from my other pharmacist colleague, but for antimicrobial stewardship programs, the CDC core elements and IDSA SHEA guidelines establish that members should include an ID physician and a clinical pharmacist with infectious disease training. I did not have ID PGY2, but in Green Bay, we take what we can get, so I help out when I can. Optimal programs would also include clinical microbiologists, information system specialists, infection control professionals, and epidemiologists. One 2016 global systematic review and meta-analysis of 26 studies performed by Karenka and authors found that ASP implementation resulted in about a 19% decreased pooled percentage change of total antimicrobial consumption in hospitals. In the ICU, this was even more pronounced. That reduction went up to nearly 40%. Use of restricted antimicrobials decreased by about 27% with ASP implementation, and broad spectrum use decreased by almost 19%. Total antimicrobial expenditure would decrease by about 34%, and hospital length of stay decreased by about 9%. So the implementation of ASP is pretty substantial. You'll also get reductions in resistance markers, so reductions in infections due to MRSA or carbapenemase production, or ESBL, Klebsiella, for example. Even at smaller hospitals, without access to specialized ID physicians, pharmacist-led programs can have significant impact. One single center observational study conducted in Spain from 2022 found a reduction in antimicrobial use of 213.3 antimicrobial use days, which are per 1,000 patient days. So with the implementation of a stewardship program, two methods that we use in tandem are prospective audit and feedback and formulary restriction with pre-authorization. So pharmacists will review antimicrobial use after initiation and then provide feedback to the providers. This will be part of our daily review, as my colleague outlined. And the benefits of this approach are that it maintains prescriber autonomy, allows for more clinical data to be available for recommendations, provides educational benefit, and can address de-escalation and duration of therapy, typically during hospital rounds. For formulary restriction and pre-authorization, this requires approval before certain antimicrobials can be prescribed. So typically these antibiotics would not be available for prescribing without an infectious disease physician or an ID pharmacist. And this table on the left is a list of the restricted antibiotics that we have at Bellin. At Bellin, our choice is to allow providers to prescribe these antibiotics, and an infectious disease physician is consulted by default whenever one of these are ordered, and then they have within 72 hours to order it. And that way there's no delay in therapy, so we kind of have that give and take. So an ideal program setting would have pharmacists conduct daily prospective audits for hospitalized patients receiving antibiotics with the following systematic approach. So there'd be a morning review where the pharmacist would query the EHR, usually EPIC, and identify all patients on antibiotics. They'd perform a clinical assessment, so they'd review the indication, the culture results, susceptibilities, clinical stability markers, renal function, and duration of therapy. They would document their interventions, so propose any recommendations for optimizing the therapy, de-escalation, dose adjustment, or discontinuation, and provide that communication to the provider and the team. And then ideally, they would track acceptance rates and clinical outcomes. That part is a little difficult. You know, at a larger institution, you're probably going to have something like that. At Bellin, you know, we're still a fairly small institution. It's like 150 beds. Our program currently doesn't have time for that, but in an ideal setting, that's what you would have. So at Bellin, we have pharmacists assigned to different decentral floors, as well as central pharmacy, and they're responsible for monitoring antimicrobial use in each of the patients under their care. On the right is a list of potential automated notifications that a pharmacist would receive to kind of direct them or prompt them on, you know, how to review an antibiotic. So in this particular patient that I took it from, these ones in bold were the ones that would show up in our patient list, but any of these are possible. The unfortunate thing about this list is that it's not smart enough the way it was built. So, you know, just because it says cellulitis duration greater than 5 days, the scoring system here is not built to tell if the patient has cellulitis. So, you know, if they're on antibiotics for over 5 days, it'll trigger. And then we have to sort of assess whether or not they actually have that condition. So it can be helpful, but, you know, anyone that's on antibiotics greater than 3 days is going to have this UTI duration greater than 3 days populate. So it's just part of the assessment we have to make. One cross-sectional survey of members from IDSA and Pediatric Infectious Disease Society, as well as SHEA, found that pharmacist interventions achieve about an 88 to 95% rate of acceptance for their interventions, and most interventions are classified as having a major or moderate clinical impact. So each 0.5 increase in pharmacist FTE, or full-time equivalent, predicts a 1.48-fold increase in odds of demonstrating program effectiveness, and that's mediated primarily through the ability to perform this prospective audit and feedback. A lot of the review that we do goes around, you know, looking at renal function, body weight, albumin levels, therapeutic drug monitoring, and then conversion usually to oral therapy. In these, you know, renal function, albumin levels, and therapeutic drug monitoring relies heavily on lab collection and interpretation of those labs. For renal function, we're looking at things like, in the septic patient, augmented renal clearance. So this is usually creatinine clearance greater than 130. And the reason that's important is that when your clearance, you know, your kidney function improves, we may have to dose adjust and actually increase the amount of drug we're delivering, or extend the infusion rate of that drug, primarily with beta-lactams, since the killing function is time over MIC. So we'll run, Zosyn instead of over 30 minutes, we'll run that over 4 hours. Cefepime, meropenem, those will get run over 3 to 4 hours if they're on that antibiotic. Alternatively, a septic patient can also be in or have an acute kidney injury, and we'll have to decrease possibly the dose and or frequency of the medication. So that happens fairly common. Really, the only common antibiotic you don't have to adjust renal function or adjust for renal function is ceftriaxone. Most of the other ones are going to have some sort of renal function adjustment. And then body weight is also a factor. The most common antibiotic that we have to adjust body weight for is vancomycin, because we use vancomycin all the time. Generally, we're going to be loading like 20 mg per kg, and then the maintenance dosing is probably going to be based on adjusted body weight in a patient who is obese. Although other antibiotics that would be affected would be aminoglycosides, so gentamicin, amikacin, tobramycin. Typically, gentamicin is used most often, but that's something we would have to account for. So there's that. Albumin levels come into play. Usually, you'll see it more for calcium in patients with hypoalbuminemia. Calcium will be falsely low, so you'll have to make a correction for that. So, when you get that calcium lab, you just have to make that interpretation. But it also affects drugs like valproic acid and phenytoin. For antibiotic consideration, the package insert for ertapenem recommends avoiding use of ertapenem because it's so heavily protein bound to albumin that when you have low levels, you have more free concentration in the blood, so it gets cleared out of the system quicker and may not treat as effectively. I found a prospective cohort study from 2015 by Zussman and authors that found that ertapenem was associated with increased 30-day mortality when it was used in patients with hypoalbuminemia. So, that's an important lab too that we take a look at. Therapeutic drug monitoring, we'll see that all the time with vancomycin and aminoglycosides, so those lab levels are important. Not too much to say there. And then lastly, we'll take a look at conversion to oral therapy once the patient is improving. But the overall takeaway from this slide is that AMS is responsible is about the responsible use of antibiotics, and the labs that are collected and interpreted are helpful in achieving that goal. So one helpful tool that we have that microbiologists help develop is the antibiogram, which is a hospital's cumulative report of isolate sensitivities over the past 12 months. So how might this help us? Recently, the IDSA published guidelines for treatment of complicated urinary tract infections. And within these guidelines, there's a recommendation that empiric selection of an antibiotic be stratified by severity of illness. So for patients with septic shock and a suspected urinary source, the selected antibiotic should have greater than or equal to 90% efficacy. And for those septic patients without shock, your empiric antibiotic should have greater than 80% efficacy. So I've highlighted E. coli here, since that's the most common pathogen for UTIs. And we can see that at Bellin, cephalosporins retain good efficacy against E. coli. Over 90% of E. coli isolates are effectively treated by third and fourth generation cephalosporins. So in sepsis, patients are going to be put on broad empiric therapy fairly quickly, because each hour without antibiotics is associated with a 7% increase in mortality. And we want to cast a wide net to reduce that. So typically, you'll have patients put on cefepime or Zosyn, and in the context of our urosepsis patient, we can think about if that additional pseudomonal coverage that you get from cefepime or Zosyn is needed. Usually, E. coli is going to be the main culprit, but there's some cases where this additional coverage could be needed, like if the patient has a history of pseudomonal UTIs or an indwelling Foley catheter, like chronic cath, or if they've been in the hospital a while and this is a nosocomial infection, the likelihood that Pseudomonas is going to be a factor increases. Per the guidelines, Bactrim is a preferred treatment option for uncomplicated UTIs, though if we look at the antibiogram, Bactrim, brand name for trimethoprim and sulfamethoxazole on the right, we'll see that the sensitivity, the isolate sensitivity is only 83%. So, just because it's recommended doesn't mean it's necessarily the best choice. At our institution, we might go for something like nitrofurantoin, which retains 97% efficacy. For uncomplicated specifically, I should say. So a little bit about sepsis. As was previously stated, due to the surviving sepsis guidelines, all patients are going to get started on IV fluids, broad-spectrum antibiotics, and vasopressors, the order being norepinephrine, vasopressin, and epinephrine. And this is all going to happen in the ICU. The graph on the right is from a landmark study from Kumar and authors in 2006, which demonstrates the relationship between survival to hospital discharge and the duration of hypotension before effective antimicrobial therapy is initiated in septic shock patients. So, patients who receive effective antibiotic therapy within the first hour of documented hypotension had a survival rate about 80%, and each hour of delay was associated with, on average, a 7.6% decrease in survival. So that's why it's critical that these antibiotics are started as soon as possible. Other labs we'll look at for these septic patients include lactic acid. The critical threshold is greater than 2 millimoles per liter. Hypotension requiring vasopressors plus lactate greater than 2, despite fluid resuscitation, identifies patients with a mortality rates around 35 to 40%, though it can be higher. Lactate is generally collected every 2 hours, and a 10% relative decline in lactate levels indicates improvement with resuscitation. Lactic acid alone is not sensitive or specific enough to determine sepsis and can arise from many other factors, including cardiogenic shock, heart failure, trauma, DKA, medications, others. So it's more about the clinical context with that picture. We'll also look at white blood cells, looking at leukocytosis, leukopenia, band counts, neutrophils. If there's a bandemia and we're looking at a left shift, this could be indicative of an infection. For procalcitonin, levels greater than 0.5 nanograms per mil supports bacterial infection. Greater than 2 suggests bacterial sepsis. Procalcitonin is helpful for pharmacists in not in initiating antibiotics, but in discontinuing them. So when the lactate level comes back and it's relatively low, this might indicate that bacterial infection isn't causative, especially if the blood cultures are negative. And if we see this relative decline in procalcitonin along with improvement in the patient's clinical status, then we can kind of use that to guide switching from an IV antibiotic to a PO antibiotic. The reason why that matters is that anytime you're administering something IV, you put the patient at risk of infection, so oral tends to be preferred if you can manage that. This slide is just a general course of how common infections will progress in the hospital. I mean, with community-acquired pneumonia, UTIs, bacteremia, you're generally going to collect whatever sample you need, whether it's blood cultures or a MRSA swab in the case of CAP. Treat for a few days, wait for those cultures to come back, and then eventually get them switched to a PO antibiotic. In C. diff, you're going to get a PCR and an enzyme immunoassay and interpret that. PCRs are frequently positive in patients. One thing you have to watch for with interpretation is that they've had these episodes, 3 episodes or more of diarrhea in the past 24 hours without laxative use. And then with the PCR and the EIA should both be positive with those symptoms of diarrhea before you progress with treatment. There is a little bit of wiggle room. The PCR can be positive and the EIA can be negative in patients with 3 or more episodes of diarrhea in that time frame, and a clinician may want to treat. That's sort of gray but acceptable within the guidelines, so that might be something we proceed with. One big thing for community-acquired pneumonia is the MRSA nasal swab. If that comes, a lot of these patients with pneumonia are going to get started on vancomycin, and if the MRSA swab comes back negative, that's usually a pretty good indication that we can stop vanco. The MRSA swab has a negative predictive value somewhere between 97 to 99%, so it's a very good tool for getting vancomycin discontinued. That's a big lab that I like to rely on. Other than that, if we are looking at blood cultures and MRSA's not coming up, we're probably going to switch them to something a little less broad, or we're going to de-escalate to something that just covers MSSA. There's no need for that MRSA coverage. So the reason why we like to get people off antibiotics is because they are not harmless. There are negative effects from antibiotic use. Every additional day of antibiotic therapy carries measurable harm. 1 in 5 hospitalized patients receiving antibiotics will experience an adverse drug event. The most common are GI effects at 42%, renal effects at 24%, and hematologic side effects at 15%. The umbrella review by Curran and colleagues analyzed 71 RCTs and found that each day of antibiotic therapy is associated with a 4% increase in odds of experiencing an adverse event and 9% increased odds of severe adverse effects. For antimicrobial resistance, each day is associated with 3% increased odds of developing resistance. For C. diff, each day of beta-lactam therapy increases CDI hazard by over 2%. And the greatest risk is Zosyn, which is a broad spectrum that many patients are started on empirically. So it's good to get that de-escalation. A 2025 retrospective study of nearly 7,000 hospitalized patients conducted by Gilboa and authors found that antibiotic exposure shows a nonlinear relationship with C. diff risk, which is that curve on the right that kind of plateaus in the middle and then increases more dramatically at the 14-day mark. Patients receiving concurrent antibiotics during or within 60 days after C. diff treatment have nearly 5 times the risk of recurrence too. So something we want to watch out for. And using relevant lab markers to truncate or de-escalate therapy helps reduce this harm. And then Tyler, I think we just had a, oh yeah.
Yeah.
We were preparing the presentation with Michael and Sherry, and we were talking amongst our institutions and the differences in practices. We were starting to kind of bullet down some questions that we were generating. In case you guys in the crowd didn't have any, we would have some for them to answer. So, Heather, I'll let you start here.
Sure. So these are some of the questions that kind of came up in discussion that I would ask the question and ask my pharmacy colleagues to give your perspective. So first question is one I asked earlier. So we did a blood culture ID of, we got Staph aureus, MAC-A positive. Is there value from pharmacy in getting a susceptibility result, even if it means it's going to take 24 to 48 hours?
So I do think there is value. So the MEC-A gene is really only going to tell us whether there is resistance to beta-lactams. We don't even know whether vancomycin is susceptible at this point. Generally is, but there is resistance there as well. And then we want that final culture data to help us when we're de-escalating an antibiotic as well. So we want to know what oral options are susceptible for the patient.
Yeah, I agree 100% with that. The only thing I would add is that for many for many institutional guidelines on vancomycin use, you'll have a table that says, okay, here's your patient age, renal function, and weight, and based on the indication, here's the dosing you might want to use. The underlying assumption in tables like that, or online calculators when calculating a vancomycin dose, is that the MIC is 1 or less. So it's important to get the sensitivities to come back, because if it's at 2, then that underlying assumption is incorrect and your dosage might be off, and vancomycin might not be the best option, because while you can increase the dose to overcome that MIC, that puts the patient at risk of nephrotoxicity and the other problems with vanco. So maybe it's better to just switch off that drug when you get a result like that.
So just the call out there of the MICs I thought was also interesting when Heather and I were talking too, because I think most labs do report out MIC values along with their their general interpretation of susceptible, intermediate, resistant. I think we've seen over time some conversations about reporting MIC values or not reporting MIC values. So we found that interesting to hear that from the pharmacist. But then I also thought, okay, now what you run into Haemophilus or something where maybe you have to drop discs to do your susceptibility test result. So how are you, now you're not getting an MIC value, now you're only getting a susceptible, intermediate, and resistant because we have to do disc diffusion testing for susceptibility and TARP. How are you guys then approaching it without the MIC value?
I mean, I guess if you don't have access to that information, then you just have to make do with what you have, right? At that point, I would have to trust that the interpretation and analysis from the lab was valid and accurate. That's what I would base it on. That's all we would have, right? It's just the trust.
And then generally, this kind of goes to number 3, but most of the time I am looking at interpretations for the MIC values. Certain instances, I think they are important, such as vancomycin, but generally speaking, I'm looking at what the lab points to.
So, Michael, as you were talking and you mentioned, it's a guideline with the MIC value here. So I kind of wrote that down because, there's been a number of breakpoint revisions over the years, and I think some labs, are more quick to uptake and implement the new CLSI breakpoint revisions than other labs. So I found it interesting that, you have IDSA out there saying to look at some of that, then based off that, you're making that interpretation. But then we have labs that are maybe using potentially outdated breakpoints for cephalosporins or carbapenems or anything like that. And, is that something that you guys are aware of and take into consideration? Is that potentially the lab is not utilizing the most up-to-date, the 2021, the 2022 breakpoint recommendations? Maybe they're still stuck in the era of 2015.
So I did ask Heather a little bit about this and whether we actually have access to the breakpoints, and we do not. So if we needed to look something up, we could probably find some information, but staff does not have access to the MIC breakpoints.
We actually had a circumstance recently with gentamicin that we had to correct, where I think it was last year, wasn't it, that the change window effect, where it was no longer recommended that Pseudomonas be treated with gentamicin, but our reports were still coming out showing gentamicin as sensitive. So, that's something that we were working on getting corrected, and I think has been fixed at this point. Other areas where the MIC might be helpful, it kind of depends. I recall recently, I think it's with, is it with urine cultures and Pseudomonas? Is that, yeah, so I guess I don't fully understand it, but for our urine cultures, we can only report if Pseudomonas is sensitive to Zosyn, but the measure is not validated, I think, for reporting out whether or not Pseudomonas has intermediate or resistance to Zosyn. So it will say if it's sensitive, but it won't report out, and we just have a note on there saying, like, you know, this test is not validated. So I'll look at the MICs of the other antibiotics to make that assessment, I guess. I recall recently there was one where cefepime, I think, had an MIC of 8, which is, I think, almost borderline. I don't have the MICs memorized, but 8, I think, for cefepime is about on the border. So looking at that, and I think ceftriaxone, I kind of, you know, assumed that Zosyn was probably not the best option. This patient was on Zosyn, so, you know, we ended up switching him to a fluoroquinolone, I think. That's one situation where, you know, I had to recently assess the MICs in sort of a unorthodox way.
All right, my next question. As a pharmacist, do you assess each culture, specifically blood culture isolates, to determine whether you'd consider it a contaminant, or would you rely on the lab report to say this may be a contaminant, or is that something you decide on your own?
So we do assess the cultures as the best of our ability, of course. I was asking Heather a little bit about this and how they're collected. So if we'll see 1 of 4 cultures is positive, you know, we may be more suspicious that maybe this is a contaminant. Does depend on what the organism is. So if it's like a common bacteria on the skin, you know, may be introduced during blood draw. Something not commonly found on the skin, maybe more of an actual infection. And then, yeah, I think.
Yeah, I think, you know, if it is 1 in 4, like gram-positive cocci, if the patient's not, you know, exhibiting signs of illness, that's going to be a contaminant 100% of the time. I don't mind having something from lab, you know, on there saying this is a contaminant. If that's a service that's offered, I'll take all the help I can get. You know, I'm not gonna deny that assistance. I still think it's appropriate for a pharmacist to review these cultures and make a determination themselves. But yeah, any additional help would be fine, I think. Yeah.
Yeah, I think that's a good call out. Not something I think, you know, I think sometimes labs oftentimes don't want to stick their necks out and say if something is a contaminant or not, even though they may be thinking it. So when you're suggesting that, it just is, it's intriguing to me because it puts the potential out there for labs to consider. You know, how would you phrase something like that in a report? You know, potential contaminant, consider other clinical signs and symptoms. You know, at least us suggesting that we believe it's likely contaminant, but ultimately, you know, that care decision really falls to the provider, the pharmacist, to kind of further pursue and work up. So appreciate that insight. The last one on here we had was, are genetic resistance markers helpful, or is it just more alphabet soup? So you think about obviously the different blood culture ID tests that are out there, and there is a large listing of some of the genetic resistance markers that are called out.
So I do find these helpful, especially with positive blood cultures. Some of these are more obvious and more commonly known. Others I may have to look up myself. But we do have references available. We want to obviously select an empiric agent as soon as possible with a patient in sepsis. So any clues that we have are important. And then especially being in a smaller rural hospital, we may not have some of these medications a patient needs. So maybe we need to order something or get them transferred out. So any kind of information that we have immediately or soon, rather than waiting for the final culture susceptibility, is important.
Yeah, I think, you know, these are frequently one of the first pieces of information that we'll get are these resistance markers, and that can be particularly helpful if MEC A is negative, maybe we don't need vancomycin. We could just, we probably wouldn't if MEC A was negative. We could just switch to, something that would cover MSSA. For, Van A, that's typically seen in Enterococcus faecium and conveys vancomycin resistance. So, if we had a patient on Enterococcus and we had them on vancomycin, that's an early indicator that we may need to pursue a different treatment option like daptomycin. Some of these other ones, we don't see a lot of these either, but the CTXM, for example, is going to convey a lot of broad beta-lactam resistance. You'll probably have to use a carbapenem for that. Even cefepime and Zosyn will kind of get obliterated by the CTXM. Some of these others like KPC, that's a carbapenemase producing. So you'd have to use something, even more broad, like a carbapenem and a suicide inhibitor like meropenem, vaborbactam sort of thing. So having these show up early is pretty helpful, because some of the frequently used antibiotics are not going to be effective if some of these are displayed. I hope I never see NDM. I think that's New Delhi metalloprotein. That one's particularly brittle.
Thanks. I added this question only, we are currently validating a newer assay for our blood culture ID, which now has all of these on it. And so in discussion with our antimicrobial stewardship team, my kind of question to the group was, would it be helpful if I actually see one of these to have it insert a comment like MEC A confers, right, resistance, like here's what it means, here's what it applies to. And so that's what we're implementing with our new instrument, is that if any of these are positive, it will throw in a comment of here's what this resistance marker can mean, and here's what you could use to treat instead. So that's kind of the reason I threw that question on there. We're small, so for Sherry and I to see some of these resistance markers other than MEC A are very rare. So I think we would all be Googling to look them up otherwise to know what they actually mean.
I think we can probably go to the next slide. I have more questions, but I want to make sure we have plenty of time.
Sorry, I wanted to comment one thing. I think, it sounds like sometimes, there might be concern about, like Tyler said, overreach or sticking out a little bit. And I think that typically happens because the view is that, maybe an experienced provider is going to be looking at this, but at least in the case of Bellin, we also have students, and, many hospitals have students. So I think there is benefit to putting these more, like what might seem obvious on an interpretation might not always be, especially at the student level or the learner level. So, adding these factors, I think, is generally a good idea for that purpose, at minimum.
Thank you. I think this is my slide here, so I'm going to hand you that.
Sure.
So I kind of went back through, some of the laboratory outputs that are out there, and one of the things I highlighted earlier was vendors coming in and pitching new product and overproduction within lab. And one of the things that we wanted to highlight, there's obviously a number of things that are going out, and I think our two pharmacists here really hit on the way they're using some of these different, more common tests that we're familiar with today. So I'm going to kind of jump down to the bottom here with the cell-free DNA NGS. It's an approximate 0 to 12 hours from a positive culture. Sorry. But what you're getting here is an organism ID. You're not getting any type of genotypic, well, potentially genotypic, but generally not. An organism ID alone with no susceptibility results genotypic or phenotypic. How is that helpful to pharmacy? Is it helpful to pharmacy? Or are you likely just going to keep the patient on a broad spectrum anyways? So organism ID, something like 0 to 12 hours from a blood draw, and you're not getting a genotypic or a phenotypic AST. You're just getting this person has, E. coli or a Corynebacterium ulcerans, right? How impactful is that to pharmacy? Is that actually adding value from a lab
to pharmacy to patient?
Like if we're just getting the bug,
You're just getting the bug.
I mean, I definitely say that's less helpful. I mean, there's less you can do with that. We would probably be forced to use, well, I mean, how would you even develop the antibiogram? I was going to say we'd be forced to use the antibiogram, but if you're not getting sensitivities, how would that even get developed? You could make assumptions, I suppose, about usual sensitivities. I guess if I saw E. coli, I would presume ceftriaxone is effective, and then I would have to look at the clinical picture of the patient, you know, to determine if they're getting better on ceftriaxone, and if they are, great. But if they're not, I'd probably have to assume, you know, maybe it's an ESBL positive ceftriaxone and switch to like a carbapenem.
In a situation like that, are you ever then, as the pharmacist, requesting maybe a procalcitonin be drawn to make that determination?
Yeah, I guess that is my default assumption, is that that would be drawn, you know, at minimum. Getting like a, you know, CBC with differential procalcitonin, all these markers are probably, I guess it was my assumption. Sorry, I don't want to hog the mic.
I'll just add that it can be important or helpful if we look at past culture data too. So if we have an organism, you know, maybe the patient has had something similar in the past, or we know they've been resistant to this particular bug in the past, we can, you know, make an assumption that they may be now.
As the pharmacist, are you guys ever placing an order for, say, a CBC with diff or a procalcitonin?
I'm not. I don't think we have I don't have the authority to do that. I would have to ask a provider and then get their permission to do that. But it is something that is built into the order sets such that I would likely never have to.
Okay. All right.
So
Yes.
Goes with that topic, because I know PCT is not used in my organization the way it should. As a pharmacist, what interval would you like to see the biomarkers, especially on a known septic patient in-house? Daily, every other day, kind of which markers, kind of at what intervals?
I wouldn't mind daily. I think that would be fine. I don't know how much it costs, to be honest with you, though, so that's something that would have to be looked at. You know, if it was 48 hours later, that'd be fine with me too. I've seen at least at Bellin, we generally don't get a repeat procalcitonin unless, you know, they're severely septic. But I tend to like more data, you know, because it helps me make an evaluation. If I can trend lab values, I find it to be helpful. As long as it's not too costly, you know, or burdensome on the institution, I'd be fine with a every day or every 48 hours for, you know, maybe 3 draws.
we do have a procalcitonin protocol for pharmacists. So for sepsis patients or pneumonia patients, we can order the procalcitonin ourselves. We'll generally check it at least every other day. I mean, daily would be great, but it does depend on the circumstance as well. There's about a 24-hour half-life, so depending on renal function, we would like to see that cut in half by the next day or whatever. We just want a trend, whether the patient's improving or not.
Thanks. This next slide, just again, additional emerging technology. I'm not going to spend too much time here. Just we're running out of time, and I want to give time to the audience in case you have further questions as well. But again, in red, some of the emerging technology that's out there. To the column next to it, hours to that result from a positive culture. So, generally 8 hours for some of these things that you're getting, to the right there, the result type. In the second one down there, the FAST ID and AST, you're getting some limited organism ID potentially with a phenotypic AST within 8 hours of a positive culture. The volatile organic compounds. That's about 8 hours from result or to result from positive culture. And again, phenotypic AST. So I'm going to leave it. I think we've kind of hit on a number of the things there. So I don't want to hit you guys too much more. I want to see first if we have questions from the audience for our pharmacists. Feel free to fire away, raise your hand.
So what are your thoughts on repeat testing for, like, generally speaking, ESBL, MRSAs? So right now, it's kind of interesting. We went through a total change in EMR to Epic Beaker, as well as like a lot of Green Bay areas. And so we've had a lot of discussions with each other on some processes, and this is one that we all do slightly differently. So whether or not we repeat ESBL, MRSA, and how beneficial it is to you, if it's harmful to have that delay in that result, how you feel about that.
Are you saying like you've identified this organism previously,
As an ESBL,
like 30 days ago?
no,
Okay.
in the moment.
Oh, okay.
Yep, so maybe they have a marker of ESBL, but it's still a protocol, at least right now for us, something we're looking into as a facility based off of kind of other responses from other labs. But we get a positive ESBL, we repeat it automatically to confirm that positive ESBL, even if they have a history.
Okay. Versus just releasing it to the chart and letting them.
Right, so MRSA is one that if they have a history, we don't repeat. ESBL specifically, we repeat. What are your thoughts on that? Is that necessary?
Having a potentially a day delay in your process.
So we can result out anything that wouldn't produce an ESBL result, but you're still waiting on that ESBL.
How long?
It would be an additional probably 24 hours.
I mean, I personally, I think I'd rather not. I'd want the initial result immediately. Would there be any harm in releasing both, like releasing the initial and maybe putting a note in that release or disseminating education to clinicians that a second one is coming for confirmation? I think that could be helpful. I would rather have that immediate result as soon as possible. I want more information now so I can start moving things in the right direction. Waiting a day, I don't know, I personally, I don't like that.
I think the hesitation is if it very rarely changes, it's usually the same, but if it does, it's a corrected report, which then on the laboratory kind of looks, not so great for CAP compliance reasons. So that's where kind of the big debate came from. Currently, what I decided to do with Beaker, now that we have a lot more capability, we had Meditech before, if anyone ever used that, we try to result out what we can and then usually put a comment that we're repeating the ESBL, but don't result that to the chart until we repeated it.
Yeah, I mean, I would have to agree with that. We want to know right away
Right
if
away.
there's some sort of ESBL. I think it's important, or at least have some sort of clue that that's likely the case.
Good. I will take that to the work group. We have an entire micro group in the Green Bay area right now that's making these decisions, so that's good for them to know too.
Yeah, I mean, generally speaking, I think that is general guidance for micro labs is to do that repeat, right? And I think it's probably ubiquitous throughout micro labs to do that process. So I think it's a great question. I think the follow up to that too would be how often does it actually change? And it does. There are times it comes back and it's no longer ESBL positive, so it's not like it's rare. I mean, it does happen. I guess I'd be curious to know. I haven't looked at the data to see how often does it actually happen to warrant potentially doing that routinely.
Mm-hmm.
And then do we see that more frequently on one system versus another? Is that Phoenix versus the Vitech versus the track or something else?
I personally have never seen it change. So that's another reason why we kind of discussed it. We use Vitech, again, I don't know. But personally, I've never seen it actually change. I've seen where things maybe don't make sense right up front, like, oh, this doesn't look like it would indicate a positive ESBL, so then we repeat, because we do get hiccups in instruments, things happen. Maybe it wasn't completely pure to begin with, but I've never seen something that is ESBL positive then be negative, so just food for thought. I don't know if other folks repeat right now and if they're holding that result, but.
Thank you.
Question down here? Oh, okay, go ahead.
Were you going to follow up on that? Because I'll let you go first.
I was not, no.
But the gentleman there
Oh,
was.
were you following up on that? Go ahead.
I'm from Beloit Memorial Hospital. In the beginning, when we started to see E. coli ESBLs, because we hadn't been accustomed to seeing them, and I would say that was within 5 years, we started to see an increase in those particular strains. We'd occasionally would repeat them because what is this? We're not used to seeing this. or maybe the MICs, because we look at the MIC values too as a kind of a screening method to maybe predict that you could have ESBL before the instrument, in our case the Phoenix, does a ESBL screen to maybe try to confirm if it feels it's an ESBL. But once we started getting them, they just started to explode. And so we kind of went by the antibiogram to see relatively how quickly these ratios of ESBL to non-ESBL E. coli's were changing. And it just got to the point where the results were duplicating. So we stopped, and we just, as long as the purity plate looks fine, the isolate we look has MICs that kind of suggest that this ESBL screen should be accepted as a confirmation of ESBL. We went with it. Then last year, we saw something we had not seen hardly at all, and we would repeat those MICs. We would have Klebsiella pneumoniae. In our facility or state line area with Illinois, we just weren't seeing ESBLs with Klebsiella pneumoniae, and we were very thankful for that. Something happened this last year, and all of a sudden the numbers started going up, getting Klebsiella pneumoniae ESBLs, and their MIC profile is different from our E. coli ESBLs. So the doctor might have a different look at what they're treating with beyond the fact that it is an ESBL, but the alternative drugs, the susceptibility patterns between those two organisms appeared to be different on our antibiograms. So now we don't repeat susceptibilities for those ESBLs because the doctor wants them as soon as possible. Right now, currently though, with CREs, we repeat. If you have like ertapenem, meropenem, carbapenem resistance, or there's a screen alert, which I don't understand very well. It'll do classifications, class A, class B, whatever, carbapenemase. We repeat them because we just simply don't have that much familiarity with them in the clinical lab at the moment. So I guess our decision to repeat something is on how frequently it occurs, and the data we've had that suggests that the reproducibility of the results was pretty good to begin with.
Thank you. Eric?
How much time do you have left in this session? What are you doing on time?
I was going to throw one of my timeout cards right now. I just spoke with Dan. He was okay with starting the panel discussion a little bit late, and I still want to make time for a break. So,
I'll limit myself to one then.
I love the discussion that's going on right now. So, if we break at 10:20 for 10 minutes, and then we start the panel discussion at 10:30, are you guys okay with that?
What time is it now?
10:12.
Okay, I'll limit myself to one then. So a question, just a general question for the pharmacist. By the way, thank you for showing up. This was very good. I was sort of interested in that CLSI comment about breakpoint changes. And my question to the pharmacist, and this, don't speak from personal experience, just speak from a general knowledge of your profession as a whole. How cognizant are pharmacists of breakpoint changes? Are there professional pharmacy societies that advertise or publicize, hey, there's a breakpoint change coming this year? Because obviously with CLSI, they change every year. So how cognizant is the profession as a whole of these breakpoint changes, or are pharmacists really relying on laboratorians or microbiologists for implementing these changes?
I don't know if there are pharmacist organizations that are reporting that out. I would say to a large degree we are reliant on microbiology to make that assessment. If any were, it might be Society of Infectious Disease Pharmacists. They might have something on that. More recently, I personally was looking at the CLSI changes because I guess I'm weird. I was looking, just to see what I could find. I was trying to find just more information to see if I could create education for pharmacists, but I think by and large, we're probably reliant on microbiology unless, we have dedicated time to pursue a project like that on our own.
I asked that question because I know there are pharmacists that do contribute to the M100 document. So I was curious if there are societal, publicities. Sorry about that.
I guess I would say it's possible. I'm just not aware of it. So forgive my ignorance.
I am not aware of any either, so I think this is a large opportunity maybe for pharmacists and learning this information. I think it would be very valuable, but as I was asking Heather before, I don't even know what some of the breakpoints are. We don't have access to them, and I think this would be very beneficial.
Thank you. Other questions out there? So more of a generalist side tangent here, but one of the other things you had mentioned earlier on too was the laboratory values, right? And you called out bandemia, and I thought that was interesting and intriguing. And how valuable is that to you guys? And the reason I ask this is because if you're familiar with it, how many of you here report bans, or how many of you here follow CLSI and CAP's recommendations to not report bans and group it instead with your segmented neutrophils? So how many here report bans still? Are you familiar with? Is there anybody here that's not reporting bans and grouping it couple?
We literally just stopped like last month.
Okay.
It was a massive fight. It was something to see.
Yeah. Okay. Yeah, I was just kind of curious because that's something we've talked about with our, joining together with our Gunderson colleagues and looking at not reporting bans because of there's so much user-to-user subjectivity variation that if you look at the literature on it, it's essentially if we're reporting 5 bans, that variability could be that there's actually 0 or there's actually 15. So it's just kind of interesting when you look at the literature and how much variability there is. So when I hear bandemia, and I've heard that from some of our ICU providers, they want to know what's the band count. And from a lab perspective, it's just really interesting to see how that's still utilized so strongly today in a lot of different areas. So from a pharmacist perspective too, and how you're looking at that, I just found that interesting. So.
Yeah, I think it can be helpful. It's just another clue, basically, that leads us, towards the direction of, do we suspect, bacterial infection, or is this due to something else? It's just sort of something we're looking at, immediately to make that determination.
Yes, I'd have to agree with that. A lot of these markers are nonspecific and just reflect inflammatory responses. So even just the other day, we have, a patient's white blood cell count increase, and we're wondering, well, is this due to the steroids they're getting, or is it the infection's getting worse? So sometimes those other markers are helpful.
Okay. Other questions from the group?
I'm from Pro Healthcare in Waukesha, and I'm curious a little bit more in general terms about the antibiotic stewardship program that you have. I saw on one of the slides that talked about who should be absolutely part of that and who is nice to have, but I didn't see that ED presence, emergency presence. I'm curious, those of you who have a robust antibiotic stewardship committee, who has ED involved, and if so, how do you keep them engaged?
We have ED, and it's very hard because they're usually working, so they never show up in person, but they're usually on a call. That's it. They're usually on a call.
We don't have, from a pharmacist perspective, we don't have an ED pharmacist covering. I guess what I can say is it can be difficult. I mean, they're probably going to start them on, something broad or even an antibiotic if it's not needed. Recently, I implemented a pharmacist-led urine culture review. So pharmacists that will review urine cultures that are collected in our ED, and we'll take a look at those. And we treat a lot of asymptomatic bacteria in our ED. Sometimes asymptomatic abacteria, I've noticed. So, you know, it's a bit of a struggle. I think it just takes, you know, you can take a few measures. One, a soft approach is just conversation, disseminating educational material. And if you, I guess, really wanted to get them on board, you'd probably also implement some sort of forcing function in EPIC, you know, requiring them to select an indication on the antibiotic and ensure that the, you know, probably some sort of prospective audit and review on that antibiotic before it's allowed to be verified. Something like that could work. I don't know that I've found the exact answer to your question yet because it's so early in this program. But I don't know, maybe we can talk in a few years and I'll let you know if anything develops from that.
So from our perspective, we do have an ED member as like optional on our antimicrobial stewardship committee. They get every invite, but due to schedule and time constraints, they don't typically attend our meetings. We have, though, at times identified ER opportunities, either presented from the pharmacy, like maybe pharmacy identified some opportunities in antibiotics that were ordered or things like that, or from the hospitalists who are part of our committee. Maybe the hospitalist sees something started in the ED that they're always changing. And so then, you know, kind of working back with the ED has worked better for us, but they, I don't think, have the staff to dedicate time to come on a routine basis.
All right, you guys, I think we'll pause here for a break. Fantastic conversation, and I appreciate all of your help in facilitating these conversations. We will take a break right now until 10:35. Why don't we give the four horsemen here a round of applause, okay?